Good morning, everyone. Thanks for having me. Thank you, Tulio and Akari for the introductions. Yes, I'm Sheetal Silal, and I'm based at University of Cape Town at a disease modeling group called MASHA. As Kari said, that's Modeling Simulation Hub Africa. The first thing you'll note is that we really don't have anything disease or health related in our names, and that's because based in the Faculty of Sciences, we're based in the Department of Statistical Sciences and concerned a lot with with methodology and being strong in a variety of skill sets. But what we have found over the years is that our primary application is in the disease modeling and in the health space. So what I'm going to be talking about today is, as you'll see from the title of my presentation, leveraging data and simulation to guide decision making and operational needs, is really through a series of examples telling you how we have supported and are currently supporting a number of governments around the world using mathematical modeling and simulation, and really whatever technique or methodology is required to answer the questions posed to us in the health sphere by these government and other health related organizations. So through these examples, I'll be presenting to you the lens that we take when we do policy modeling, what we focus on particular, and really some key enablers that allow our modeling to have impact. All right, so what we're really talking about today is moving beyond the academic space where we don't focus is a wrong word. We don't really care too much about publications and academic requirements, citations, and these things. They come much later. And so what we really focus on when we are doing any of these disease modeling work, this kind of responsive work for governments, is our primary goal is to provide the answers to governments. And now, in our experience, policymakers, they don't read journal articles really, maybe perhaps in spare time. And so what we do is we generate the content that they will engage with through presentations, through technical reports, applications, direct engagement with the decision makers themselves. And then maybe a year later, we'll find the time to write up the publication that goes with the work that we had actually done. Does it benefit us as academics? Probably not so much, but at the same time, we get to be doing some very impactful work. And for us at MASHA, we do value that higher. And we're lucky that our university also values that and appreciates that the publications come later. So let me tell you a little bit about what we do at MASHA. As I said, our primary focus is policy relevant disease modeling or mathematical modeling. And so this is interdisciplinary by nature. When you do mathematical modeling, yes, maths is in the name, but we need to be good at a number of things. And I'm sure in your fields, you realize this too. You've got to be able to be a good or a decent programmer or work with very good programmers. You've got to be have a good nuance or understanding of biology, epidemiology, medicine, economics, finance, public health. And that's particularly important for us because we're working in this space where it's about a finite pot of money that needs to be spent on health. And you often need to justify your recommendations that you're making in monetary terms as well. So an understanding of the public health system and the financing mechanisms that go with it are also equally important. Does it mean you need to be adept or a master in all of these skills? No, but you do need to be astute and aware enough to know when and who to engage with as in terms of the real experts and bring them into the room so that you can engage effectively as a group. And so mathematical disease modeling for policy is by nature interdisciplinary. At MASHA, we engage in a number of diseases. Prior to the COVID pandemic, I would say our bread and butter at MASHA was malaria, and I'll speak a little bit about the malaria work that we have done. COVID came, and unfortunately, we could do nothing else besides COVID at the time in terms of responding to our government. But post-COVID, I'd say that our work at MASHA is half on vector-borne diseases, And the other half is on vaccine preventable diseases. So working on, diphtheria, tetanus, pertussis, measles, rubella, and so on. And geographic scope, we spend about 30% of our time working on South African problems, being a South African institution, but we serve LMICs around the world and have a large presence on the African continent in terms of supporting African governments with a number of African partners. We use a variety of methods, like I said, but not going to dwell on that right now. Just touching on some highlights. And let's talk first about what we would call routine support. It is routine support, but it is serving a particular need in this case. Here is a South African example. It was some work conducted in 2018, 2019, so prior to the COVID pandemic, and it was an investment case for the elimination of malaria in South Africa. Now, malaria elimination is a global drive. There's political commitment from the presidencies across the world to eliminate malaria by certain dates. South Africa had missed its last two deadlines for a number of reasons. There were some large, regional outbreaks, and much of it was due to climate. There were operational challenges, and so on, and we had missed our deadlines. But we do not receive money from outside donors like the Global Fund. We've got to fund our malaria program from our national treasury. In South Africa, HIV, TB, these are major health concerns. Now, how do we advocate for spending money on malaria when you're trying to eliminate it? Eliminate means it's very much at a low level already. So it's not really a health problem. You've got other major health problems, but you have a goal you want to meet. So we had to come up with, number one, charting the path, advising the government on what they would need to do in order to eliminate malaria, and two, cost it, and three, help them ask for money to fund the actual program. And so what we did here was, number one, this had to come, and here's how we conduct policy modeling. This desire for modeling had to come from the National Department of Health. And so the National Department of Health contacted myself, and we together formulated, okay, this is what needs to get done. We need to develop this investment case. It means we need to have economists on board. We need to have people who are part, who understand how a national treasury works, who can craft this mechanism for us to actually get and ask for this money, and how it's going to, where we're going to get the money from. We then established a technical task team that comprised entomologists, public health experts, clinicians, and other experts in malaria, regional experts in malaria, all who understand malaria. And we, as the mathematical modelers with the programming expertise, I myself have financial expertise, we brought all these brains together in a room to then say, okay, what are we going to test? What are the scenarios? What is the government capable of doing? Let's try that out. Let's see if it's going to eliminate malaria or not via a mathematical model. Let's build this model, validate all of our assumptions, get our data from the South African government, meet with the people, with the managers in Limpopo, understand what's happening on the ground, understand what's happening on the ground in KwaZulu-Natal, in Mpumalanga, and come together and craft an investment case. So we did the mathematical modeling to simulate the path to elimination. We then did the costing to figure out how much it's going to cost. And then together, we crafted the presentation that was to be taken and delivered by national government to Treasury. And we were lucky enough that a few months later, the Minister of Finance they accepted our proposal and committed 319 million rands towards our South African elimination drive. And that was a direct impact of modeling, or a direct outcome of a modeling exercise. And this investment case was considered so novel and well orchestrated that the WHO at the beginning of last year actually awarded the country and recognized the country with an award due to its efforts in developing and enacting and obtaining funding on this particular investment case. If you want to read more about it, I should have perhaps put the links on for the publications. There are publications that I must say came out in 2021, 2022, though the work was actually completed in 2019. And you could read those to understand, one, how the models were developed, and two, how we managed to work out the financing system that would allow the money to come from some other allocated budget, but into malaria. So what you can see is that modeling is only part of the process. If we just developed a model and then we step back, we wouldn't have been able to do any of this advocacy work or work with the government to actually get the outcomes. So we had to not just stay at stay at our computers. We had to move beyond making recommendations and helping the governments to implement those recommendations and translate it into cash. And so we've been dealing with investment cases like this around the world. At MASHA, you can see one of our projects was developing the exact same type of investment case for 22 countries in the Asia Pacific. We've worked in the Guyana Shield, which are a number of countries on the top of South America. We've worked in Melanesia, and all this while doing very much the same, building different models for different countries because each population and health system is different, but trying to answer the same questions about how we're going to get to elimination and how much it's going to cost. So this is in a non-emergency setting, which means these types of projects, these number and level of engagements, the protocols we had to observe, each of these projects took about 6 to 8 months, and some of them took over a year even of continued interaction, which means that as a modeler, you need to be dedicated to see that that type of interaction through. So when the COVID-19 pandemic hit in early 2020, we found ourselves as modelers in a very different space. So at the end of March, the South African COVID-19 Modeling Consortium, the SACMC, was formed by the Department of Health and convened by the NICD. And just listed my colleagues and Kari, as she had mentioned, from SACIMA, we had the then head of SACIMA, Juliet Pulliam, who was also part of the consortium, and that's where we all got an opportunity to work very closely together. So firstly, to note that here, it's very fast acting response. So it's not like you're going to get 8 months to develop a model and come up with an outcome. By 8 months, the whole first wave would have been over. So when we were asked to to formulate this consortium, we were 3 or 4 different institutions who were suddenly smashed together and working together for the first time. So we had to make sure we were all going to be playing nicely, which is not traditional for academics, but if we go on the premise that we are all nice people, it can actually be done very easily. And it was. For us, it was actually quite a breeze for all of us to be working together. And so we had to answer questions almost immediately. How many masks are we going to order? What's the worst this pandemic is going to be? Do we need to build up more systems now? We're going to put the tenders now. So how many drugs do we need to order? Do we need to order more ventilators for us needing them in 6 months? You take these questions, and then you realize, but hold on a second, COVID is new. We don't know anything about it. Every day, new information is emerging. I still recall members of the Department of Health texting me every morning at 6 o'clock. We saw this new paper. Are you going to include it in your model? We found this new paper. And now you think about the pressure that you're dealing with while the country is, going into lockdown and you're trying to buy things, you're trying to work out your own family issues and so on. Here you are taking on this additional pressure of, okay, I'm trying to build a model, but this new information is coming in every day. Things are changing. How on earth are we going to be able to deliver on the outcomes that are expected of us? And so we learned a couple of lessons very quickly. And one of those lessons was that we really did need to be agile and update our models very, very regularly. So in the beginning, we started off with very sort of I would say, simple compartmental model for COVID-19. And NCEM stands for the National COVID-19 Epidemiological Model. If you Google that along with some of our names, you'll pick up the papers quite easily. Whilst some of our colleagues in the UK and Europe were all, were developing agent-based models, and we were working with a somewhat simpler population level model as opposed to an individual person level model, we came under that criticism almost immediately. Why aren't you using an individual person model? These are the more complex models of our times. Our computers can handle them. And that's where you got to say to colleagues that, you know what, we don't have the data to train these models, to create. Of course, we can build these complex models. That's not the difficult part. The difficult part is justifying their use and training them appropriately with the individual level data in our country. And we did not have that data. And so we chose methods that were appropriate to the level of data that we had. And I was still quite capable of answering the questions we needed to answer, right? And so we started off with a simple model, but 50 iterations later, we ended up with just keep on building and building and building and building, such that our model became a model of 9 provinces. At some point, it was 52 districts as well, with 4 variants in them, 7 age groups, and 3 risk populations. So it's almost like if you take the first model and then you multiply, you take 9 times 4 times 7 times 3, that's basically how big that model really got. And then we were faced with other challenges. And this is where sometimes we realize you can't just be a good mathematician, you also need to be a good programmer, because we were being asked almost daily by the Minister of Health, calling up, do you have your updates today? Do you have your updates today? The president's talking tonight. We need your updates now. If your model takes a couple of hours or a day to run, you're not going to make the deadlines that are required of you. And so it's not about even just a single run. We know that in order to incorporate heterogeneity, uncertainty, we've got to run our model many times. We've got to run it stochastically, run it 10,000 times, 100,000 times. That takes time too. And so we had to code our models very efficiently, develop efficient pipelines to push each model out in a matter of seconds so that we could, in fact, run the model 10,000 times, 100,000 times. And we came to the point sometimes where we were developing some, providing recommendations, not just to national government, but to provinces too, on a phone call with the Western Cape Department of Health. We're in my dining room with my team. That was our emergency center during the lockdown. On the call with the Department of of Health in the Western Cape, and my colleagues we were generating the output and formulating it through the pipeline to create all the plots we needed whilst the presentation is ongoing. So it's coming almost like we're doing a Google Sheet a Google presentation, Google slide presentation, and the slides are being developed as we're speaking. And I mean, can you imagine the pressure of doing that to still try to make sure you provide robust results, right? So a crazy time, but we learned many lessons, right? One is you've got to be agile and you have to be adaptable. When new information is coming up almost on a daily basis, you know you're going to have to change your models, your systems. You've got to be efficient how you develop the system so that reproducibility is very easy and adaptability is very easy. You've got to be able to not be set in your ways. That comes with methodology as well. We have to change our methods. And what you see here is a series of different kinds of outputs. When we started off, we were providing provincial level engagement during the first wave. And then the provinces came to us and said, you know what, but actually we want to make decisions at the district level. That's our decision-making spatial granularity, not at the provincial level. Can you provide district-level projections? Next thing we know, we are on the phone with Vodacom. I still remember sitting at Juliet's house with you eating pizza, Kari, and I was on the phone call with Vodacom, trying to make sure we get the data and using the minister to say, the Minister of Health is asking for results tomorrow. We need the data from your portal right now. And we couldn't get it from the portal. They had to be emailing it to us and crafting little packages of data, tailor-made packages of data for us to get spatial connectivity to do a district level model. And so we then had to suddenly make up a district level model and get connectivity in place. But now, how do you present 52 districts worth of data? Ain't nobody going to read that report, right? So what do we do now? Next thing you know, we've got to develop an app in order to show that you can now select each provincial manager can go in, select, okay, that's my province. I've got 6 districts. Let me look at my districts. So within 2 weeks, my team developed an app. And these are some of the outputs from the app. You'll recognize, those of you familiar with Shiny will recognize the styling, where we suddenly had to develop an app to show 52 districts worth of projections, ICU admissions, hospital admissions, projected deaths, cases, trends, etc. Right? Then beta comes along, and suddenly we suddenly don't know anything again about how the beta variant is going to manifest. In the month preceding Tulio's announcement to the detection of the beta variant, we already were seeing increases in cases, and no one knew why. Government said, please build your models. We're seeing the second wave now. And we said, hold on, we can't see why we have an increase. It's not because of suddenly an increase in spatial movement, or it doesn't look like it's a decrease in public health and social measures. We can't find the driver, therefore we can't model. And they were like, no, you must model. We're like, no, we're not going to model because it's not responsible to develop this kind of model when you don't know what's driving an increase. So what we did was we changed tack, and this is where agility and adaptability is important. We decided that, you know what, we're going to build a dashboard, another application for the country, where we are going to be using just metrics of analysis to understand how an epidemic is progressing, whether things it's increasing in different spatial units or not. And we're going to link this to the government's resurgence work plan. So we're going to say, if you are past certain thresholds, you need to ramp up your testing. You need to do this for contact tracing. You need to increase staff at hospitals, or increase your orders. So we linked every mathematical metric we came up with to some action. Once again, how are we going to display this? We went to the NICD to say, and they said, you know what? Yeah, we're developing a dashboard. CSIR were also developing a dashboard. We said, here we are, we'll give you our code. Just go put it up, and we'll update it. We'll create a pipeline, go put it up onto a dashboard. But they could not be agile enough because of the red tape of their organizations. And they said, Sheetal, please, can you guys just develop the app? So now we're like, okay, sure, we'll develop the app. 2 weeks later, we now had to come up with a whole new app, launch it for nationwide access, simultaneous access, and another press briefing. And so the SACMC Epidemic Explorer was launched. I think it was a week preceding your announcement of on the beta variant, just to give the country some heads up on a few weeks actually preceding the beta variant announcement, just on, look, this is here is how you can monitor cases as they're increasing. And when the beta variant announcement came up, we were like, yeah, you know what, guys, we were right. It's a good thing we didn't model, because we would have modeled the entirely wrong thing, because the resurgence of the wild type variant is not the same thing as the introduction of a new variant into circulation, right? So completely different drivers. So what does that mean? It means that you've got to be able to analyze your sources of data and be sure that these are the correct methods to be using, and they can be justified with the data that is known at the time. It also shows how we need to be working together with people who create different sources of data. And from that point, as soon as the word variant entered the conversation, we were working with Tulio's team and the National Genomics Surveillance System, and every one of the reports that came out, there we were getting the data, monitoring the competition between variants as they were as one was coming in and out competing the other, and its impact in our models. And so my model suddenly became wild type, and then wild type plus beta, wild type and beta and delta, and then plus Omicron, then plus Omicron subvariants. And at some point I was just like, why? When will this ever stop? So exactly. Yeah, please just go. Exactly. So it stopped, and it was no longer a major problem of public health concern. So we were monitoring seropositivity of the South African population, to know when the population was largely, not going to be severely affected, and where it was not really affecting mortality and hospital admission. And that is exactly when we stopped. So with the COVID response, we supported a number of things. And I want you to see just how many different groups we supported, so that you understand how many different types of meetings and presentations over and over again we had to make. I used to call it the roadshow. Every time an output of the model came, I would schedule a week's long worth of meetings with all the different government departments and government adjacent organizations. So we were part of, along with Tulio, I think we're still part of Tulio, the MAC, the Ministerial Advisory Committee for COVID-19. We supported facility readiness, so those who were working on the number of beds, ventilators, oxygen availability at hospitals, the Affordable Medicines Directorate planning drug quantities throughout the hospital, the supporting testing algorithms, and then budgeting. And remember that everything we did got translated into costing. Our colleagues at HERO at Wits University, they were responsible for the costing side of translating our model input. So we had plenty of meetings with the Reserve Bank, with the National Treasury, and helped to plan out this entire initiative. And not just over wave one, but across all 4 major waves in the country, and then provided advice also as we were starting to see these smaller waves with these subvariants. Okay, but let me change tack now. So you've seen a little bit about funding advocacy. You've now seen what it means to do modeling in a responsive setting and all the different lessons that we learned there. But in the aftermath of the pandemic, though mathematical modeling has been used to support policy in the last 100 years, it's really not a new thing. It did gain a lot of popularity during the pandemic. And so the requests for modeling started coming quite thick and fast, that governments were starting to become willing to incorporate modeling as part of routine decision making. So this actually happened. This is a project we applied for prior to the COVID pandemic. It was delayed from the WHO, and eventually we started on the project late in 2021 during the pandemic. So here we doing a project to support the Ugandan government to introduce booster doses of DTP vaccine. So those of you who are in the medical field or have kids will know that babies receive 3 doses, the primary series of diphtheria, tetanus, pertussis vaccine at 6, 10, 14 weeks of age usually, but there are booster doses at 18 months, at 4 years, and at around 9 years of age. But not all countries have booster doses. And so it was necessary to develop a model that there were no models that were jointly looking at the impact of tetanus, diphtheria, and pertussis globally. And so a tender was put out by WHO, which we applied for and were awarded to develop this world first type of model, where it was an application that is required to not just develop 3 disease transmission models that are linked by the same vaccination, but to explore the introduction of boosters with them and to cost it out and put it all into an application. So not a very small ask, and not one that you really want to be dealing with in the middle of the pandemic, but it's been a long process, and we're at the completion stage. So you can see here we've got 3 different types of models for 3 different diseases: tetanus, pertussis, diphtheria, and it is a compartmental model structure which is quite suitable for these 3 diseases. And it's age stratified into 56 groups. So you can imagine each of these structures replicated 56 times for 56 age groups. And they are, what you can see here are the key features of the model, that they include all the different types of vaccines. It has to include things like your fertility rates, contact and mixing patterns. And then we take all of our disease outputs and vaccination outputs, and we link them economically to work out the economic case, to get costs of treatment, costs of vaccination, the cost of introducing the vaccine, your programming budgets, and so on. And so, yes. The pretty colors, yeah, sure. It's just different stages of infection. So in the top here, we've let me show you here. So this would be yeah, this is pertussis. So here we've got the primary vaccine series. So you'd have vaccine 1, 2, 3, and then your 3 boosters. And then it's a question of how the vaccine for pertussis works, whether you are protected or not protected. So we've got to account for both stratifications. But from these, now you're able to get 4 different types of infection, where it could be an asymptomatic pertussis infection or a symptomatic pertussis infection that is severe or non-severe, or even an atypical manifestation. Pertussis is woefully underdiagnosed because it doesn't present very clearly symptomatically. So we've got to take all of that into account. We've got to allow for the vaccines to wane in their protection, and we've got to allow for natural infection to be giving you a full level of protection, or full immunity as well, and allowing that to wane over time, hence the need for boosters in the first place. But yes, yes, exactly. And it's more like removed from infectiousness with, in this case, the R is a place of full protection. But also remember, given this is age stratified, we've got to take into account fertility, because mothers who get Tdap, which I think is the current South African policy, you get Tdap vaccine during pregnancy, you then confer 6 months worth of maternal immunity to your babies. So now we've got to take into account these mothers and take parity into account, that they get vaccinated. Some are vaccinated, some are not. It wanes over time. Mothers are protected. They will produce or give birth to babies who are then also protected. And that's where this M sort of comes into account of terms of maternal immunity and for the babies and so on. So it's quite a complex structure because they linked by age and vaccination. So if someone is, let's say you have received your second dose of Tdap. So if in Tdap you can hear that it's got T, D, and P, that means for all diseases you will move one step higher for vaccination. But there's another vaccine called TD, which means it has tetanus, diphtheria, but it doesn't have pertussis, which means that if you are on your second dose of tetanus, diphtheria, pertussis, and then you get TD, T and D will move to their third dose worth of protection. P will stay back in its second dose worth of protection. So it is a complex setup. But we've managed it, especially with respect to teamwork, to get a very nice and efficient structure, to get this running in a matter of 1 or 2 minutes, really, between using our Google Sheets and our Shiny. And it's important for us to develop, obviously, a free interface without using other complex paid for software, because this is for public health. This is for governments and governments all around the world. So here's just a sneak preview of the app itself, just to show you what we have created. You can see the work is through the CDC, who funded this through, got this through WHO, working with Affinet on the continent. We created the DTP booster strategy tool, just some sort of instructions. And then it's kind of this interface here, where you can see you've got to pick for each country, pick your dose target age for your primary series. Decide which vaccine is it. Is it a pentavalent vaccine or a hexavalent vaccine? What is your country policy? How are you delivering the vaccine? Because that impacts cost. If it is a facility-based program versus a community outreach, right, versus school-based program, they all have different costs. So you need to pick your delivery mechanism here. This is a health facility because of the young age. And then you're basically setting your current status. Do you have booster vaccinations? What are they? Notice that the first booster here is a pentavalent vaccine. The second one is TD, what I mentioned only, tetanus, diphtheria. Third one, tetanus, diphtheria. Where are they delivered? It becomes quite complicated. You could see actually on this side here that we then have another section for all your health system characteristics. What's the likelihood of going for treatment if you have a tetanus illness, if you are sick with diphtheria? Pertussis, for example, what's the likelihood of diagnosis in country? What are the costs of procuring the vaccines right now, the cost of delivery? All of these are inputs that a user puts into the app itself. And we then have a section on developing strategies. Are you going to now introduce the childhood booster alone, look at its impact, or childhood booster plus adolescent, and so on? So here's a sample page from the outputs. Here we've got the baseline, which is your current status quo, the introduction of an infant booster, and the introduction of infant, child, and adolescent. So the three boosters. And we can see then impact across the three diseases. This is for all ages combined. But then we offer opportunities here to look at different outputs, to look at different age groups, to view your outcomes as counts or per 100,000, all the things that matter for those consuming and needing these outputs. And then we have some tables at the bottom, along with a costing analysis. So what you're seeing here is that these are now a comparison cost, where you've got the cost of vaccination and treatment costs for your infant booster, infant, child, adolescent booster. And then there's a cost of introduction. You can then look at the total annual cost and do a comparison from your baseline. And we piloted this application in Uganda. They were our first country to pilot this application, and this is now almost complete, where we're delivering the final report at the end of this month, which is next week, which means the pressure is on at the moment. And we were in country, working with the country, working and trying to navigate all the, the computational issues that go with it when people are using an app at the same time. It's a very resource intensive app. What happens when the internet fails? Should we have an offline solution? Is there what are the best ways to actually work through such a complicated app? So we had several workshopping sessions. And I'm glad to say that the country has now, through the app, decided on the strategy that they are going to be implementing in terms of which boosters they're choosing to introduce. And now it's a question of the final report. And once again, decisions are made now or in the last couple of months. The papers will only be submitted for publication maybe towards the end of the year or next year sometime. We have, so that would be an example of some routine support. So looking at time, just to give us enough time for questions, I'll just talk a little bit about some of our current projects that we're doing, and I'm going to scoot over this quite quickly now. The COVID pandemic did raise one very important outcome. Aside from us as modelers learning lessons on the African continent and in LMICs in general, the one very big lesson we learned is that unless you're lucky, like a country like South Africa, to have not just one but a number of disease modeling institutes, there are other people doing your modeling for you, and you don't have local country expertise. On our African continent in particular, MASHA supported, we supported Mozambique, MASHA supported Namibia, because there were no modelers in these countries, and that's a problem we have to solve. So with that, we're currently, we are in the middle of a Bill and Melinda Gates Foundation grant to build modeling capacity. We're currently training 13 African PhD candidates in modeling. And these candidates are from a number of countries. In fact, with the postdocs we're training, we are looking at around over 11 African countries. These candidates are all working with their governments. So their governments are partners, and they're doing projects in direct relation to malaria, in their case, the malaria needs of their country. So this is a very large project, and I think just adding 13 PhD modelers to the continent will be a great asset to the continent, because whilst I'm training them to be malaria modelers, I'm also very much training them to be modelers, as in they engage in consultancies on schistosomiasis, on rubella, on measles, on many other aspects of disease modeling, so that whether it's the next pandemic or the next local emergency hits, they will be equipped to developing models for any disease, not just being experts in malaria. We also realized at the same time that in the world of malaria, especially with climate-sensitive diseases, it's not that easy to engage in certain data sources. So climate data, for example, might be quite readily available or publicly available, but it's not readily accessible. there are 20 different outlets where you can get temperature data. But which is the right temperature data to use? Is it maximum temperature? Is it daily temperature? Does it matter if it's remote sensing or weather station data? What is the correct data to be using for retrospective climate analysis versus prospective projections? So with these types of questions around and realizing how it is not always accessible or not always easy to understand where to get data from and how to use it analytically, we are creating a Wellcome Trust through a Wellcome Trust funded project. We're creating a repository called Health Radar, where Radar stands for Responsible Access to Data for Analysis and Research. And in this repository, we are collating and curating data sets that are already available elsewhere, pointing out to where they are, providing chunks of code on how to access them, contextual notes on what to be thinking about when using this data set, as well as examples on how to visualize with the attached chunks of code, how to visualize the data and how to use it for analysis and modeling in a meaningful way. So this project is underway. If any of you are interested in this space, the pilot is on malaria. If anyone is interested in this space, please do reach out for us. We're doing a pilot of our repository in the next few months, and we'd be happy to bring you along, include you in the pilot. And later on, the next 2 years, we'll be spending a lot of time developing a community of practice around this repository. We're also engaged in, I see it's cut off at the top just a little, but that's most likely my fault. Another project from the beginning of next year. So it's another Wellcome Trust project called CAMISA. Here we're focusing on vector-borne diseases in Southern Africa. So not just malaria. And of course, you hear me saying Southern Africa, not South Africa. So not just malaria, but also chikungunya, also dengue, and looking at other climate-related, not necessarily mosquito-borne disease, but climate-related vector-borne diseases like schistosomiasis, which is a big problem that we need to be dealing with as well. We're developing a consortium of 8 countries and their institutions, their research institutions, to be providing research and climate-relevant research in the mosquito-borne disease space in our region. And with this, again, the ministries of health are all involved. The local institutions are involved, as well as advocacy partners. So we have already laid out this pathway to impact before the project even starts. And this is the importance of partnerships. So I think I'm going to stop there in the interest of time and to allow us to engage a bit more in questions. To end off, just to say that from the range of projects that we've presented today, you can see that as a modeler, it's not enough to just be a mathematician or just to be a medical doctor. Modelers come from all different parts. Some people are medical doctors and they become mathematical modelers. Others are epidemiologists. Some are physicists. Some are mathematicians. I, for one, I came from actuarial science, so I came from mathematical finance and into this space. And from operations research. So you can come from very many backgrounds, but the importance is that if you want your work to have impact, you need to be working with a team of people and working with the decision makers from the very beginning, because that enables co-creation and that enables acceptance of the tool, working together and providing all that very important contextual information that mathematics and numerical data are not able to provide. And as a modeler, you also need to learn to be responsible for the projections that you make and do what we call knowledge translation. When you give out your recommendations, that's not where you stop, but you work with the clients, with the governments and decision-making partners to help translate your outputs into implementable decisions. So with that, thank you for your time, and I'd be very happy to take questions.
Thank you so much. Yeah. So 2 things. Yeah. Carrie told me to be very nice to Sheetal, which we are. Yeah. But as part of the seminar, yeah, we have this seminar every month. Yeah. We really engage with a lot of questions and we normally grill the presenter. So in case they ask, it's not us trying to be unpolite with you. I think that is exactly the opposite. Yeah. So please, that's your chance to engage. Yeah, just for you to know, Sheetal, as part of that, we also have a big training workshop now with people from 19 different countries. Can you put your hand up? Yeah. And many of them come from like Nigeria CDC or Eswatini Public Health Institute, yeah, which they may have to be involved sometime with modulars. So now it's open for questions. Let's take a couple of questions here. And please don't be shy. We're still very nice to our presenter. And then we're gonna take a couple of questions online. We had 150 people online at the moment. So we really value you taking your time, yeah, online but let's engage with nice questions and answer. And yesterday was my time to grill them. They were presenting here, so you saw how I did, so you are welcome to do again. So please.
Thanks, Sheetal. Do you have anything specific? Closer?
Yeah.
Okay. Do you have any specific lessons from your COVID government work experience on communicating uncertainty without completely discouraging the policymakers? Like, how do you strike that? How do you know where to strike that balance?
Thanks, Jeremy. I think that's very, very important. And one of the ways that I think one of the best ways to communicate uncertainty is to do it often. And instead of a once-off meeting where you're saying, oh look, my range is from here to here, and then running away and never coming back, I think is that's one way in which you can really where you don't leave enough time for explaining. Whereas if you present this and then you come back and say, this is the reason why it is the case. So visually representing something, contextualizing it into, why is it this wide? How might it be made narrower? Are there is there data that we can take into account? Perhaps it is this wide because we're looking at a whole population or a whole province. For this area, we might expect it to be in a certain way. I think for me, I've found it always sort of more beneficial to have visual aids and discontinued repetition to be engaging with the government partner as to why things might be uncertain with respect to the data, because our models are very much just based on the data that is provided by government. So always reflecting the question back onto the data and seeing why that data may not be the most representative of a certain situation, I found to be quite useful.
So I have the next question. Firstly, thank you. This was such an inspirational talk. You're making me want to be a modeler as well. I really appreciated the investment in capacity building within Africa, particularly the core skill development. You've spoken so much about the importance of stakeholder development. Now, as a master's student on his PhD, we hardly get that opportunity to learn how to speak to the policymakers. So that is absolutely fantastic. I commend you for that. I wanted to just pose a question about the DTP work. That was wonderful. Thank you. There's so many compliments. How agile would that be if in the face of new vaccine developments, because now costing needs to change because of that? You just mentioned the hexameric and the pentavalent. Something new could be out there, and I would think it needs to be changed immediately. Is that possible?
So firstly, the vaccines, or rather this DTP tool, has been developed with WHO. So the WHO have given us a list of 20 or 30 vaccines that we need to have included already, that countries may already choose. And so there are two ways in which a new vaccine that is not yet part of the WHO schedule could be incorporated. One is to be looking at its characteristics, because it's not about the vaccine name, it's about which disease is it actually affecting. And a new one will probably almost just always address all three, but it might have a different efficacy, or it might have a different waning period or duration of protection in terms of its build-up of doses. So you could look at other vaccines that are quite similar and use that as a proxy, or you could be reaching out to the WHO, to your WHO counterparts, because countries don't just change decisions like that. They usually are engaging with WHO policy to then say, look, is this going to be introduced or not? In which case they would then come to us, and we would easily. I mean, it is very easy to do it because it's about, in our case, it would be adding a row to a Google sheet with the name of the vaccine and its characteristics, and then that would, because of how we've set it up for the 20 other vaccines, it would then translate already into the mechanism that is set up. If there was a new booster age, like a fourth booster, for example, that would be a bit more mechanistic work we would need to be building. And once it's involved, it's included into the WHO recommended schedule, then we would be able to update that.
Thank you.
Thanks, Sheetal. I think the back row is dominating with the questions. Not for long. You spoke about adaptability and agility, and also spoke about capacity development. And I think that a lot of us in this room would be considered adaptable because we come from multidisciplines. But how do you strengthen agility, as if you think of it as a muscle? And how would you teach that even in your malaria capacity building initiative?
So what I'm doing there, I'm being quite purposeful in how I'm conducting this training. So, for example, what I have set up is a range of consultancies that my students engage in. And in these consultancies, they are working on real life projects that have far, quicker deadlines and curveballs that are thrown at you because it's a real research project. And so I put out a call for, I've got these consultancies on the go at the moment. Who's going to apply for them? And then when the students come in, it's not a question of, yes, but I've got this PhD deadline, or I need to submit this paper for this conference. I don't care. This is real life work now. So they're learning on the job. And it's something I learned during COVID when, in relation to the previous question about engaging with policymakers, you can lecture all you like to people, but experience is what matters. So when I took all my meetings, my team were around me in my dining room, silent, and they were listening, because to me that was the way in which they were going to learn. Okay, this is how you engage with policymakers. This is almost just learning on the job. And so, for example, relating back to my consultancies, we recently did a schistosomiasis consultancy for the South African government. When I went to the Department of Health, we only have one South African student on our program. I took the South African student with me because he had worked on the consultancy, and he was with me in the room whilst I engaged and made the recommendations to the South African head of department. And then he also had a chance to make his presentation and engage with them. But also, here's me thinking, he's the South African PhD that I'm training. This is the head of vector-borne diseases for schistosomiasis, who was engaging with schistosomiasis. He needs to be known to this person. So now this is also an opportunity for him to make a good impression, get his name known to a head in national department, so that the next time I'm going to organize secondments for all of my students, which is another way I'm adapting, teaching agility, I'm going to get them to be based at their institutions for 2 months, 2 to 3 months or so. And they'll be doing work for government as if they were an employee, not trying to develop models or anything, but engaging in the routine day-to-day hustle and bustle of government. So may I just say that this type of capacity building is only possible with money. You can't do this in an unfunded way. Believe me, I tried, but how am I going to fund somebody to be, spending 3 weeks in a government department? So I am very grateful to the Gates Foundation for providing the amount of money they have provided to allow us to be creative and well-rounded in how we do this type of capacity building. So next time we need to go collect data, I can send my student to Benin. I can send them to Nigeria. I can send them to Botswana on their own, or with a program manager with them, to go and actually go to their ministries, have their initial meetings. They've all had initial meetings, but then go and do their data collection, presentations, and come back. So we need more of that.
Okay. Yeah. Do I need to stop? Maybe. Yes, so again, compliments for the great work and the wealth of experience you are sharing with us. Mine is just on the same line of thought about the agility of especially your vaccination models. So I was just wondering, does it also take to account issues, right, on the opposite end? One, issues of outbreaks, because we know vaccine preventable diseases, sometimes because of coverage or whatever reasons, you get pockets of outbreaks. So how adaptable are these models to that? That's on the one end. And then the other end is the issue of vaccine stockouts. So you get either from the manufacturer of a country curing and those problems that come with that. Are the models able to advise on that?
Okay, so DCP Boost was built with a specific purpose, which is the introduction of vaccine. So looking at the cost effectiveness of the introduction of vaccine. So the app in its current form is for that purpose, right? But outbreak modeling is now a different kettle of fish, but you may not be able to use the app for that, but in us publishing our models themselves, these models can be used for exactly that, for routine management, looking at the impact of stockouts and so on, as well as outbreaks. So diphtheria, for example, and I think I heard Tulio say that there's a colleague from Nigeria present here. I didn't present it today. I thought in terms time. Wonderful. We were just supporting the Nigerian CDC at the end of last year for the diphtheria outbreak using our same diphtheria model and other methods, because the model incorporates the mechanism of diphtheria transmission and the mechanism of the historical vaccination. So now it's a question of saying, okay, look, the outbreak is biggest in Kano district, Kano state. Let's look at all the other states as well and look at the historical coverage. Look at the seroprevalence data that came from their areas. Look at the zero-dose children proportions in each of the different states and the other operational characteristics, health access. So working with the country, we got all this level of information. Let's put it together using the same model. May not be the DDP Boost tool, but it's the same diphtheria model, and then train that for outcomes, to produce the outcomes.
Yeah, we're gonna have a couple of questions online, but you can take if you want some water, take your bread. Yeah. So I'm just allowing the mics online. Yeah, we have Kelabete. Sorry, Habalago. Sorry if I pronounce your name wrong. Yeah. You have your hand, so what you have to do, you have to unmute your mic, and now you can talk.
Thank you. Thank you, Prof Sheetal. That was very informative. I enjoyed it a lot. I have a question on multidisciplinary collaboration. So I saw that you mentioned quite a lot of disciplinaries, but there was no mention of social sciences. So considering that social behavior impacts on how people maybe respond to the availability of vaccine and how that will then impact on, for example, how COVID will spread throughout the nation, is social behavior a factor that is considered in modeling? Is it possible to consider social behavior in mathematical modeling? Or are the models based on like maximum values, such as maybe the entire population of South Africa, for example? That's my one question. And I have another one about what was the percentage error in the NCM, and what were the explanations for the errors, if there were any? Thank you.
Thank you so much. Okay, so for your first question, yes, so maybe what I actually need to do is to edit my slide to add social science into the multidisciplinary work or team list, because we do engage with multidisciplinary, with the social science groups. And so, for example, with the questions of vaccine hesitancy and so on, by engaging with what you call the NITAGs, let's just use vaccine modeling as an example. NITAGs are your national immunizational technical advisory groups. We take into account then through their own experience and their social science research that has been done in country, what the local characteristics are with respect to vaccine hesitancy and other social and behavioral factors. A key part of even malaria, and interesting, I was having a discussion on this and a PhD related to this topic just yesterday on social and behavioral communication change. Is one of the major factors of malaria and strategies of malaria that we consider. So yes, these are often taken into account in modeling. Sometimes what we have to do, though, because the impact of social and behavioral communication is not always measured, it is not possible to necessarily include the positive impact associated with it, but we do certainly include the cost associated with such campaigns. And then what we take into account is how we take the impact into account is what I mentioned as knowledge translation earlier, where we do not have that quantitative data to back social and behavioral considerations. We then contextualize our results in relation to what is qualitatively known by local experts. So we do take it into account. It may not always be in the most traditional quantitative ways, but it is an essential part of any implementation type of modeling work. Then to your second question, that is always a question of importance when it comes to modeling. In part of our papers, we did earlier on in the pandemic, when we were more concerned with projecting cases and hospitalizations and deaths, we would every time we published a report, we would publish how well we did from the last the last projection. And often, of course, in those early days, it was a question of, how many tests are actually available. So sometimes in our results, we would put, well, if the current testing strategy continues as planned, this is where we expect cases to be. But if you relax the testing strategy and there's more tests available, the lab capacity has increased, or there's rapid tests available, this is what you might expect. At the end of the first wave, we only ever did projections in the first wave. When I say for like the kind of forecasting type of projections of cases and so on. In the first wave, we were pretty much on point when it came to deaths and hospitalizations. Cases we stopped measuring because that was a question of, again, testing availability and people's need, given the asymptomatic nature of COVID as well, to actually be seeking a test. Later on, we did what we call a scenario-based approach, where we provided different scenarios based on a population's response to basically a population's adjusting of their behavior to the different waves. And so there, within our range of scenarios, we were almost always in line with what was being projected. But that's where the agility, I think, helped us a lot, in that because we were readily updating, we were helping the country to adjust its course regularly, rather than saying, I'm making a projection once and I'm going to see 6 months later how it panned out. And so that was one way of us trying to adapt for what would be a long-term error associated with projections.
Okay, thank you. Then I'm just gonna pass to Johanna. Yeah, if you can unmute your mic and ask your question, please. Yeah, Johanna Michael with the hands on. You may need to unmute your mic. Okay, as we wait, he or her, sorry, I wouldn't know. Yeah, we have a question here, yeah. And then we're gonna give you a break. Don't worry, it's not gonna go forever.
Yes, thank you very much for the insightful presentation on mathematical disease modeling. I found it very motivating. So my question is, you mentioned a pilot study. So how can interested researchers or institutions plug into this study for mathematical disease modeling? Because where I come from, the Republic of Kenya, we have a very high mortality rate for malaria. So how can interested researchers or institutions plug into this mathematical disease modeling?
If it's malaria that you're interested in, I think the easiest thing to do would be to just send me an email, and then we'll keep your name on record for when we do the pilot of the radar project. But then if you're interested in anything else to do with malaria, I have a postdoc student based at CEMA at the moment doing malaria modeling, and many colleagues working in malaria in Kenya. And I would be more than happy to connect you where appropriate, or to at least set up some discussions to see what your needs are.
Yeah, thank you. So I'll.
Yes, please. I'm sure with through Tulio and the team, my email should be somewhere.
Okay.
Yeah.
Yes.
Sorry, I found a way to
there we go. Yeah, we'll just send that one. Yeah.
Okay. Yeah, I have one or two questions to you. Yeah, on the malaria and the arbovirus. Yeah, why are you modeling only Southern Africa when we know that, or we expect this Southern Africa, with exception of northern Mozambique, to be very low susceptibility for these pathogens? Why did you choose only Southern